I'm the partner in crime with Grant in kind of trying to improve muscular blockade monitoring in Tayside. I work in Nine Wells Hospital along with Grant. So I am passionate about neuromuscular blockade monitoring. I kind of learned about this during my higher part of specialty training, and then I've not looked back at all. There's no conflicts of interest to declare. I've attended one conference in the past that was sponsored by Merck. All the videos and pictures I'll be sharing in this have necessary patient consent, and we are not here to promote any single monitor. What we are trying to do is kind of share our knowledge and experience with this neuromuscular blockade monitoring. I managed to put up a slide. These are your answers that we asked at the beginning of Grant's talk. So the 3 questions that were asked: when do you use NMB monitor? So quite a few of you use. I mean, there were more than 50 responses, and quite a few of you use it during all phases of anesthesia, and majority of you use during extubation, and that's the kind of common practice that we come across. But only very minority that you don't use at all, and hopefully they'll at the end of the session they'll be looking forward to using these monitors. How do you assess neuromuscular blockade? I know Marcus mentioned that all you have at the moment is peripheral nerve stimulator, and David at the beginning was saying even for that you'll have to kind of make quite a bit of an attempt to get hold of them. And do you use Sycomedex? So most of you have answered it as sometimes, and which is the case most of the times. I think this is the all-important question. Why should we monitor neuromuscular blockade? When we teach our trainees and medical students, we always talk about triad of general anesthesia, which involves hypnosis, analgesia, and paralysis. So obviously paralysis is an important component of general anesthesia. But I think in practice, we probably don't pay that much attention, in my opinion. I don't think we can anesthetize these days without a pulse oximeter. And that's not got as much evidence as neuromuscular blockade has. So why do we kind of compromise and not use what we already have because there's so much evidence available? That is one reason. Or because the experts, the reason I've put these 2 pictures here is because I've worked with both of them, and obviously they have a massive amount of experience, especially Professor Bruhl is the authority in this area, and there's plenty of evidence available, and they've used that and given us an opinion to say use it. Our National Association of Anesthetists, you've already heard about this. They've updated their guidelines and they strongly recommend it. And just to give you a bit of an overview, this is just a trailer, if I can say that. Over a decade, they've just selected, Professor Bruhl and team, they've just selected a few studies to show even as late as 2016, there's still plenty of residual paralysis that happens in these patients. So there's quite a bit of evidence available, and we should be following evidence-based practice. That is my thoughts why we should monitor neuromuscular blockade. And with the hope that it improves patient safety and we can reach a stage where we can say residual paralysis is a never event. It should be a never event. I don't think we should be, in the current era, we should be looking for these kind of situations, but in practice, it's quite the contrary. I'm not going to go through all the patterns. The reason I put this slide up here is the most common mode that we use is a train-of-4 ratio. And I'm sure you all know what train-of-4 ratio is. It's got few advantages. It differentiates depolarizing blockade and non-depolarizing blockade. It doesn't need a control like single twitch. And that's probably the most common mode that we come across. But what we should know is the different levels of neuromuscular blockade. And this particular paper I've mentioned at the top of the slide, it gives quite a nice description of from the point of acceptable recovery all the way to complete blockade. What are the different modes that will help us determine these levels of blockade? and most importantly, this is, I think, Grant's phrase I really like. What we should be looking for is immobility of the patients and not paralysis of the patients unless indicated. So we should be quite closely watching for this. And as we know, majority of the surgeries only require moderate levels of neuromuscular blockade, which means we should still be able to see some TOF twitches when you objectively monitor or subjectively assess these neuromuscular blockade. How should we monitor? Again, there are different ways that we all do, and this is my personal kind of take on it. Before I say how we should, there's plenty of options available. And I know in Nottingham predominantly we have these peripheral nerve stimulators. As far as I know, I think they're going to become obsolete soon. There's no further manufacturing happening, so they may not be maintenance available. So I think we should move on to quantitative. One more reason to why we should move on to the quantitative neuromuscular monitor. With the peripheral nerve stimulator, most of the modes is available, except the train of 4 ratio. So if you're using a peripheral nerve stimulator, I would recommend considering double burst stimulus towards the end of the surgery. But if you the big advantage with the quantitative neuromuscular blockade monitor is the train of ratio. It gives an objective number for the level of neuromuscular blockade, which is very, very important. And that is the key before we wake a patient up without any complications during recovery period. How do you monitor? Again, always include neuromuscular blockade management in your plan. You talk about, to your anesthetic assistant, you talk about what kind of an airway you'll be using, whether you're going to intubate, whether you're going to be using LMA, and what monitors do you need. So include neuromuscular blockade at this stage. And both national audits, NAP4 and NAP5, quite clearly demonstrates that. And I've just included a quote here from NAP4. And Grant already mentioned about NAP5 and the recommendations with neuromuscular blockade. I think I am sure most of you would have come across this or would have heard about this. I think attaching the monitor properly, getting the basics right, is crucial for the monitors to give us the accurate result. I don't think many of us do it very well, but especially if you're going to be assessing a patient with polytrauma who's had a road traffic accident, the area could be very dirty and greasy. So that will certainly increase the impedance and may not give you the most accurate result. So clean the skin whenever possible before placing the electrodes. Ensure correct placement of these electrodes, which means negative electrode distally, because there's a study done by Professor Bruhl and team where they actually demonstrate maximal neuronal stimulation and muscular response when it's applied like this, whichever the site it is. And avoid hypothermia of the area where you'll be monitoring, because that can increase skin impedance quite a bit. And also the current intensity you use is directly proportional to the resistance or impedance. more commonly used is facial nerve and orbicularis oculi, or corrugator supercilii. This is easily accessed, but the big problem is direct muscle stimulation. So it can give you spurious results. So you need to be very, very careful about that. And I'll highlight a little bit more about it in a minute. So when you actually stimulate facial nerve and making sure it's the corrugator supercilii or the frowning muscle that is stimulating, that actually simulates intubating conditions. That gives the best results for intubating conditions. But how easy it is to find the frowning muscle stimulating, I certainly find it extremely tricky. Ulnar nerve and the adductor pollicis unit, when you use, it kind of reflects quite well with the recovery of pharyngeal muscles, closer to the recovery of pharyngeal muscles. So that's why we should be using ulnar nerve for recovery at time. So there are some limitations if you want to use facial nerve monitoring. I mean, in my personal opinion, I don't think we should be using facial nerve monitoring at all. Because as I mentioned, the risk of direct muscle stimulation is very, very high, especially if the electrodes are not properly placed. The supramaximal stimulation of facial nerve, the currents required to achieve this is lower than the other areas like ulnar nerve and positibial nerve. It's, like I said, it's technically very difficult, and we get variable results with that, because trying to see the orbicularis oculi or corrugator supercilii twitch is very, very difficult. And we obviously not going to measure how much current we are using, especially with peripheral nerve stimulators. And there's also a study which shows 5-fold increase in residual paralysis when you actually look for TOF ratio in the recovery area. So Grant did mention about applying these monitors routinely. Like I said, along with the other monitors, make sure this monitor is available, whichever you're using, whether it's a peripheral nerve stimulator or a quantitative neuromuscular monitor. It literally takes seconds. It's not more than 15-20 seconds to apply it to the patient. So by the time the anesthetic nurse has applied all the other monitors, you could just apply this and ready to be used. Almost always use ulnar nerve during induction and recovery, because, as I said, during recovery, it kind of matches close to the recovery of pharyngeal muscles, which can, if they're weak, can lead to airway complications in the post-op period. Baseline measurement is very important. Calibration is recommended if you're using acceleromyography-based quantitative neuromuscular blockade monitors, but there are a couple of machines available in the market where they don't recommend calibration, and they claim that it's not required. But whatever you're using, please make sure you use it right from the beginning, and before you give the neuromuscular blockade drug, make sure you use it, because that demonstrates the machine's working and also gives a baseline recording. And if you're using an AMG-based device, I think that could be one of the monitors that you'll be trialing at the in your hospital soon. So if you're using that, make sure the thumb is free, and you consider calibration depending on what kind of monitor you're using. One important tip that really helps me is at the beginning of the list, discuss with surgical colleagues about the arm accessibility, especially with the body cavity surgeries and the abdomen and thorax. Make sure you ask the surgeon, is it okay to keep the arm out or arm visible to me on the chest? And there'll be some pictures you could see on that how we place them. So this helps massively, because whenever you record and measure something, make sure the thumb is visible and thumb is free from any sort of interference. When should we monitor? For me, it's quite obvious through all phases of anesthesia, right from start all the way to the end. And whenever you're using a neuromuscular blockade drug. Grant already showed a different picture, but it explains the same thing about differential muscle sensitivity, because different muscles react differently to neuromuscular blockade. The central group of muscles, such as diaphragm and larynx, they receive relatively higher blood supply, so higher. They receive the higher percentage of neuromuscular drugs quicker compared to the peripheral muscles. So you see them getting paralyzed quicker. At the same time, they recover quicker as well. And they are more resistant to neuromuscular blockade as well. Just the bulk of the muscle is much higher. One of the studies actually talk about the myosin that's there in these muscle groups are much higher compared to the peripheral muscles, and that's why the resistance is higher in these group of muscles. So what is the practical application to this? So when you use a dose-based neuromuscular blockade agent at induction, whichever way you're using, sometimes you may see a TOF count of 0 and TOF ratio, TOF count of 0 before intubation, and sometimes patient may cough a little bit, or you may see some diaphragm movements. That's because of the variable muscle responses to neuromuscular blockade. Doesn't mean the monitor is wrong. So I always use right from induction. Also, Difficult Airway Society guidelines recommend this as well, especially in certain situations. If intubation is difficult, further attempts should not proceed without a full neuromuscular blockade. And how do we know neuromuscular blockade is full? Unless we monitor. And also, complete neuromuscular blockade should be ensured if any difficulties encountered with airway management, whether it's during mask ventilation or during intubation. And mask ventilation, again, it reiterates that inadequate anesthesia or inadequate neuromuscular blockade may make mask ventilation more difficult. Avoid big induction doses if possible, because we know this is one of the reasons which can increase the incidence of residual paralysis during the recovery period. One of our colleagues did this neat study on few patients during his practice, and we're always used to giving a neuromuscular blockade and look at the clock for 3 minutes. And most of us, I think, are impatient, and we think it's 3 minutes, and it's definitely not 3 minutes. So as you can see on this slide, definitely there are lots of patients who've taken longer than 3 minutes, especially if they're elderly or with severe comorbidities. So the only way to make sure we've had adequate or kind of good conditions to intubate is by monitoring it right from the beginning. And you could use a peripheral nerve stimulator to achieve this. I know you'll be trialing some of the AMG-based devices towards the end of this month, as Mark says. One of the things that we should know about AMG-based devices is something called reverse fate phenomenon. It's not very, very well understood, but what they think is accelerometry is based on Newton's law, force equals mass times acceleration. So it's actually the force of acceleration that's being measured in this situation. So what we assume here is when the thumb is accelerating, we just assume it comes back to the way it was before we started the stimulus. But in fact, in practice, that may not happen. So it could go back to any different positions, as you can see on the picture on the right-hand side. So that leads to something called staircase phenomenon. So every single time it comes back to a different resting position, and the thumb thinks, okay, when the next stimulus comes, it goes beyond the 100%. And that's why when the display is seen on some of the monitors, which choose to use a raw display instead of truncated display, as you can see on the picture on the left, sometimes you see a percentage more than 100%. And this can confuse people if you're not sure what the mechanism there is. And that is because of something called reverse fate phenomenon. So if you see right at the beginning, if the percentage is 120%, and if you're using a monitor such as StimPod, which is chosen to display raw TOF ratio, do not be alarmed, because this is a phenomenon of accelerometry. And we need to do something called normalization, which is, as you can see in the picture, you need to correct the TOF ratio, which is the ratio of measured TOF ratio and the baseline, which we need to do towards the end of the surgery so that we achieve ideal recovery, which is closer to 100%. So this is one thing to remember, but in practice, if you aim to achieve TOF ratio of 100% towards before extubating, this is not going to be such a problem in the recovery period. But you need to be aware of this depending on which monitor you're using. But if you're using a monitor such as TOF scan, they've manufactured in such a way that the display is truncated and it doesn't go beyond 100% at all. But there's a reference value which can be used as well to visualize this. It's one of the phenomena to remember if you're using axillomyography. Should we monitor during maintenance phase? Yes, it's a no-brainer. My answer is yes to that, because we give top-ups because of a variety of reasons. Okay, it's been a while. Let's give a top-up. Airway pressure has gone up a little bit. I can see the CO2 trace. There's a little dip in the CO2 trace. Or patient coughed or moved. Okay, we need to give rocuronium or any muscle relaxant for that matter. So when the patient coughs or moves or airway pressure goes up, most probably the answer here is patients maybe not completely, not at the right level of anesthesia. So we need to think, okay, we may need to deepen the anesthesia here before reaching on to the paralyzing agent. I'm not saying we should not give a paralyzing agent, but we need to make a plan. We need to kind of ensure patient is anesthetized before we give paralyzing agent. So in other words, continue monitor during the maintenance phase, which will help you decide when to give the top-up doses, minimize repeated doses based on time or based on the other things I just mentioned. Avoid big top-up doses, like you might have given an induction dose of 50 milligrams, which is 2 times ED95, and then the top-up doses will be 20 milligrams every half an hour. That definitely will lead to residual paralysis. And like I said, what we need to achieve here is immobility and not paralysis, unless it's absolutely indicated. I'm just going to run a little video here, just to mention the importance of keeping the thumb free. Ensure thumb is free for accuracy of the results. Always, when you measure these recordings, whether using a peripheral nerve stimulator or AMG-based device, always take 2 to 3 consecutive readings, because it gives you consistency of results. So as you can see on the video here, on the left-hand part of the video, these 2 recordings are done consecutively. The left part of the video shows lesser ratio as compared to the right part of the video. It's purely because the thumb is not free on the left half. So make sure the thumb is free when you're using axillomyography, and take 2 to 3 consecutive readings, as I said. No access to arms, is that an issue? Yes, sometimes, depending on what kind of surgery that's been happening. So there are some alternative ways to achieve this. One of the ways is EMG-based device, and I know Mark is bringing a monitor which is based on EMG. So speak to Mark and try and use that. That is one of the alternatives. And we also have something called TOF cuff, which is based on compressor myography, which is basically like a cuff, which is not dependent on free thumb movement. Though from the monitor point of view, yes. But what if you don't have a quantitative monitor? Still, it's not the end of the world. I certainly wouldn't recommend using facial now, even if you're use it with caution. Ensure you're paying attention to where the ECG dots are placed, where how much current you're using, what muscle is being twitching, and then try and reduce the chance of direct muscle stimulation. Personally, I would never use facial nerve. Towards the end of the surgery, make sure the hand is accessible again. Monitor your neuromuscular blockade at the ulnar nerve, and then make a plan to reverse the neuromuscular blockade. Yeah, again, this is just an infographic to show what you could do if the arms are tucked and hand inaccessible. I've already described about the limitations of facial nerve monitoring and how tricky it is to monitor these 2 small muscles. And if EMG or compressor myography is not available, in other words, a peripheral nerve stimulator is available, plan jointly with the surgeons, minimize top-ups, use when clinically indicated, if you're using facial or tibial nerve, revert to quantitative ulnar nerve monitoring whenever possible. If not, at least use a peripheral nerve stimulator on the ulnar nerve. Assess block level to guide reversal drug choice, and dose to ensure TOF ratio is at least more than 0.9. Or for practical purposes, make sure it's close to 100%. I mean, the only way to achieve this is quantitative neuromuscular blockade monitoring. So try and get some more experience with that. Again, just to reiterate, how we can get the best out of an AMG-based device, if you're going to be getting that in your hospital. So as the pictures show, make sure the thumb is always free for movement and it's easily visible. Just to reiterate, measure 2 to 3 responses with 15 to 20 second intervals for consistency before and after any action like top up or reversal or recovery. Ensure that recovery TOF ratio is more than 90%, ideally closer to 1 if truncated display, or more than 1 if raw display, like I explained about reverse fade and normalization. When can we extubate the patient safely? What does the consensus say? What do the experts say? What does the evidence say? We need to make sure TOF ratio is more than 90%, or in other words, make sure it's almost reaching 100%. Recovery can be achieved in three ways. It could spontaneously reverse and reach the 100%. If that's the case is all day and you've not used muscle relaxant since induction, it's not because it's not required. You may reach this, or use neostigmine with glycopyrrolate or Sigma-Dex. And Grant is going to speak more about strategy that's involved there. But a couple of things to highlight here is two things. I mean, if you're using clinical tests, you can see even with TOF ratios less than 0.4, patients can do most of the clinical tests, and they are not reliable at all. Even if you're doing more than one clinical test at the moment, the evidence suggests the reliability is very, very poor. Sensitivity and specificity is very, very little. Equally, if you're using a peripheral nerve stimulator, which is definitely much, much better than using clinical tests alone, fade assessment works great. That's another myth. Because once the TOF ratio is more than 40%, it's even if you're an expert and you've been using it for years, fade assessment is very unreliable. And how are you going to say whether this has got fade or no fade? Or even if you're sure, okay, there's no fade, how are you going to say it's more than 40% or it's closer to 100%? It's very, very difficult to achieve that. Double burst stimulus is a little better. It's obviously you're looking at 2 strong stimuli and you're comparing first to second as opposed to train-off ratio where you're comparing first to fourth. So it makes it a little better, but once it crosses 60%, again, evidence suggests it's not the best way to confirm 100% recovery. So again, you're guessing here. So there's a big gap, and the only way to bridge the gap is quantitative neuromuscular blockade monitoring. And hopefully, in the near future, you'll be able to use some of these monitors that are available. So I'm going to just take you through a few slides before I finish my talk, just to show you the different quantitative neuromuscular monitoring at different levels of neuromuscular blockade. So this one is definitely, you can see the fade here, and it's around 20% or so. And the next one here, although it's more than 40% and it's very difficult to see a fade, it's not adequate recovery. So if you're using a peripheral nerve stimulator, you really don't know where you are. So it's best to reverse it and use a reverse agent and make sure we aim to reach 100%. And the only way you know for sure is using quantitative neuromuscular blockade monitoring. 4 equal twitches to my eyes, but you're never sure. So this video should demonstrate TOF ratio of more than 90%. You can see 4 equal twitches. So what was the difference between this and ratio with 60%? It's difficult. Without the number, it's very, very difficult to differentiate. So this is what you should be achieving at least before extubation. But in an ideal world, this is what you should be looking for, 100%. Once we reach this, I think we'll be able to safely extubate the patient, ensuring all the other factors are taken into account. What do we aim for? TOF ratio closer to 100% and aim to achieve residual paralysis as a never event. So from best practice, from top to bottom, if you're looking at a hierarchy model, always plan. plan at the beginning of the case. Don't ignore neuromuscular blockade, and plan and use quantitative monitor when it's available. If not, plan and use a peripheral nerve stimulator. And Grant is going to give an excellent talk about how to use peripheral nerve stimulator and how to use the strategy. Please do not rely on the clinical tests, and they are not reliable at all. Some take-home messages. Plan and monitor neuromuscular blockade whenever neuromuscular blockade drugs are used. Monitor throughout all the phases of anesthesia. Getting the basics right is very important, rather than blaming it on the monitors, thinking, okay, monitor is not working. Use quantitative monitor, and hopefully you'll be able to do that soon at the place of your work. Ensure hand is visible at the time of measurement. Chat with the surgeons. Avoid facial nerve monitoring, and always revert to ulnar nerve monitoring at the end, because that kind of matches closest to the recovery. Remember immobility versus paralysis, and minimum paralysis whenever required. If you're using axillomyography, be aware of reverse fade and normalization. And how to practically counter this is to aim for TOF ratio of 100% prior to extubation. Plan for reversal of neuromuscular blockade early, so keep this as part of your overall strategy, and always aim for residual paralysis to be a never event, and which will massively improve patient safety. One of the things that we all do badly at is looking after your monitors. So if you don't look after them, it's not going to help them achieve what you want to. And I've just shown a picture of how I document. This is how I document every time I use a neuromuscular blockade. So most commonly I use an AMG-based device, which is TOF scan. Start from induction all the way to extubation, and a TOF ratio. What is the ratio before I give the reversal agent? And then based on the ratio, I plan my dose of reversal agent, most commonly neostigmine and glycopyrrolate, and then ensure TOF ratio is closer to 100% before I extubate. And this is how I document, and that's from one of the actual anesthetic charts that we use. So just a mention about there is plenty of resources available. Please do get in touch with us if you're interested in any of this. And there's a brilliant podcast, and you'll hear a familiar voice of Grant in that, along with Mr. Harp Griffiths, Dr. Harp Griffiths. So it's a really, really good podcast, which is only 10 minutes long. And we are hoping to develop an educational video on a public platform, so watch the space. And this is one of the infographics that we've developed, which is quite useful in making a plan and strategy. And thank you very much for listening. And there's some acknowledgements here. And if anybody uses Twitter, please do get in touch with me. My Twitter handle is on the screen. Thank you very much for listening.